Assalamu alaikum. I am Dr. Khalid Abozguia. I'm a cardiologist and electrophysiologist uh, and the director of Cardiac Electrophysiology Service in Marshall University, West Virginia, United States. It's a pleasure today to present in the first Libyan International Emergency Medicine Conference in my hometown, Misrata, Libya. Um, there is no financial disclosure related to this presentation. We start with the first case. Um, it's a 68 years old male who presented to the emergency department with 1 week history of palpitation and cough. Past medical history of COPD, type 2 diabetes, hypertension, and TIA. The patient blood pressure was around 100/62, and this is his EKG. So you've been asked about the following option. Would you consider putting this patient on anticoagulation and then doing transesophageal echocardiogram and considering cardioversion if there is no evidence of clot inside the left atrium and the left atrial appendage? Other option would be to anticoagulate the patient and just aim for rate control and then refer the patient to cardiology service for further management. Other option would be to consider anticoagulation and chemical cardioversion, whether you use amiodarone or flecainide. And obviously, the final option would be none of the above, and whether or not you have a different approach. It's very clear from this case that we want to establish clear diagnosis of AFib. If you focus on the ECG, if you look at the limb lead, lead 1, 2, and 3, and AVF, and lead AVL and AVR, you could see clear evidence of disorganized activity, which does not look physiological and very highly suspicious this could be artifact. Whereas if you look at the chest lead from V1 to V6, you could clearly see a P wave followed by QRS, which suggests that this is likely to be sinus rhythm. To make the case more clear, if you look at the bottom 2 lead, which is the rhythm lead, you see lead 2 and V5. Lead 2 clearly shows artifact, whereas V5 clearly shows sinus rhythm. So this EKG illustrates the importance of making sure that you diagnose AFib and exclude other differential diagnoses. And one of the commonest mistakes is artifact. So the gold standard for diagnosing AFib is 12 lead ECG. So you should see irregular rhythm with no clear P wave morphology, and sometimes you may see fibrillation waves. However, if you want to diagnose AFib using rhythm strip, single rhythm strip, or telemetry strip, the recommendation will be that you should see at least more than 30 seconds of irregular rhythm with no P wave morphology to diagnose AFib. There are different differential diagnoses for irregular narrow complex tachycardia. The differential is AFib. So it's very likely to be AFib. However, there's some other causes of irregular rhythm. For example, atrial flutter or atrial tachyarrhythmia with variable block. Other possibility is multifocal atrial tachycardia, especially in patients with COPD. And the other differential diagnosis is if patient have some form of sinus tachycardia with frequent premature atrial complexes. Why AFib is very important? AFib is very important because it's the commonest cardiac arrhythmia we see. The prevalence and incidence worldwide is increasing, and this condition is associated with significant mortality and morbidity. These patients are a 5-fold increased risk of stroke and 3-fold increased risk of heart failure and 2-fold increased risk of death. More importantly, these patients has poor quality of life and they tend to be very symptomatic. The mechanism for atrial fibrillation is not fully understood yet. There is different hypotheses, different theories about how AFib initiated. But generally speaking, usually to initiate the AFib, usually there is a trigger for initiating AFib. The commonest site for triggering AFib is in the left atrium in the pulmonary vein, but we know now there is other location, sometimes even in the right atrium, like the SVC RA junction can be triggered for AFib, and there is another anatomical structure in both left and right atrium can be a trigger for AFib. To maintain AFib, especially in the persistent atrial fibrillation, most of these patients will have some form of substrate like a scar in the left atrium or right atrium to maintain the AFib, and there is different hypotheses and theories about uh, um, um, explaining maintenance of atrial fibrillation. There are different risk factors for developing atrial fibrillation, similar to the risk factor for cardiac diseases, but specifically obesity and obstructive sleep apnea. It's an area where we've seen more patients with obesity and obstructive sleep apnea. So managing atrial fibrillation, especially in the outpatient setting now, we are very aggressive in lifestyle modification, advising patients to lose weight, and we almost always, for obese patients, we recommend a sleep study if there is any sign or symptom of obstructive sleep apnea. And obviously you need to look at other modifiable risk factors shown in this slide. These patients tend to be symptomatic. Usually they present with palpitation, especially if they have AFib with rapid ventricular rate, we call it RVR. But more importantly, these patients most of the symptomatic patients have some form of fatigue and tiredness, and some of them also have shortness of breath and difficulty to exercise. Some of these patients develop lightheadedness, dizziness, and chest pain. There is different classification, but this is the commonest classification we use. So paroxysmal AFib is usually when you have AFib and self-terminate within 7 days. If the AFib lasts more than 7 days and lasts between 7 days and 1 year, we call it persistent atrial fibrillation, whereas long-standing persistent atrial fibrillation is usually more than a year but less than 5 years. If you have AFib for more than 5 years continuously, then we classify that as permanent atrial fibrillation. Now, this classification is extremely useful for us as cardiologists because it will guide us on how we manage these patients. In the ED, in the emergency department, you're likely to be seeing patients either with new onset AFib or AFib with rapid ventricular rate or a slow ventricular rate. But for the new onset AFib, obviously if they are hemodynamically unstable, for example, they have very low blood pressure or they are in heart failure, then immediate cardioversion is recommended. Then you almost always, for patients needing cardioversion, it's recommended you anticoagulate them for at least 4 weeks. Obviously, the indication for giving patient anticoagulation lifelong depend on their risk profile, and we use CHA2DS2-VASc score to decide whether or not the patient should be on lifelong anticoagulation, and we'll discuss that in a few slides. If the patient, on the other hand, is hemodynamically stable but still symptomatic, then it depends on the onset of the symptom. If you think the patient had symptom less than 48 hours, then they are less likely to develop a clot in the left atrial appendage in the left atrium, and it's considered reasonable to proceed with cardioversion, but you still have to give them 4 weeks of oral anticoagulation afterward. If the patient had AFib for more than 48 hours or the duration was unknown, then it's safer to assume that these patients are at risk of having a clot, and it's probably better if you anticoagulate them for at least 3 weeks, rate control them, and then bring them back for electrical cardioversion. And then after cardioversion, you should continue anticoagulation at least for 4 weeks. However, if the patient is very symptomatic or they prefer to restore sinus rhythm during the same admission, then it's very important to perform transesophageal echocardiogram to make sure there is no evidence of clot in the left atrial appendage. And if that is the case, then you could proceed with electrical cardioversion and still have to give them at least 4 weeks of anticoagulation after cardioversion. In the emergency department, the management of AFib starts with initial assessment with short history and focus, physical exam, and then you need to do the investigation, which include the 12-lead EKG and a blood work. If you have facility of performing imaging, and it's recommended that on the initial assessment you keep this patient nil per mouth, so just in case you decide to give them sedation or anesthesia for electrical cardioversion, so at least that it's safe to proceed. Then you need to decide whether or not your strategy is to achieve rhythm control or rate control, and then you will go to risk assessment of thromboembolism. These patients are at risk of stroke, and we use CHA2DS2-VASc score. But you also have to take into account what is their risk of bleeding, and we usually use has bled if we decide to start patient on warfarin, or we use the Orbit score if we decide to start the patient on DOAC. Most of these patients will need some form of follow-up with the cardiology or the electrophysiology for further management. If we start with the initial assessment of patient with atrial fibrillation, focus history and physical examination specifically to assess the duration of the symptoms, and then you need to see if there is any reversible cause, whether you could have sign or symptoms of thyroid disorder, and also to make sure that whether or not these patients are hemodynamically stable. A 12-lead ECG to confirm the diagnosis. Then you proceed with the routine blood work, specifically looking for any reversible causes, for example, complete blood count to make sure they don't have anemia or clear evidence of infection could precipitate or trigger the AFib. You also want to make sure there is no evidence of electrolyte imbalance. Also exclude thyroid disorder by doing thyroid function test. Some of these patients may have some form of heart failure or acute cardiac event, so it's recommended that you consider doing cardiac biomarkers. Creatinine and EGFR are very useful when you decide on what antiarrhythmic medication or what anticoagulant you want to use. If you have the facility in your emergency department, it's recommended to do target echo to look for the LV function to rule out any significant valvular disease, could explain the atrial fibrillation, and more importantly, to look at the left atrial size, which will help the cardiology and electrophysiologist in deciding on long-term management. Chest X-ray is useful to make sure there is no signs of heart failure or signs of chest infection. If you decided to go with the rate control strategy, for example, the patient had symptom more than 48 hours and the patient is relatively stable and you are not keen to do a transesophageal echocardiogram, it's very recommended that you achieve rate control and consider anticoagulation if appropriate. And usually in the emergency department, your best option is to go for medical therapy. But for electrophysiologists, sometimes you see that we consider patient for a strategy we call pace and ablate. This is usually something we leave as a last resort for elderly patient who tried medical therapy and we struggle to achieve rate control. In this patient, we put a pacemaker in and then we ablate the AV node. The advantage of ablating the AV node is we'll make sure the atrial fibrillation will never conduct to the ventricle, and that will avoid a rapid ventricular rate. But the disadvantage is the patient will be dependent on the pacemaker. So this is why this is kind of a last resort. I felt I should mention it here just in case you see patient being treated by pace and ablate strategy. For rate control, you have several options. It depends on whether or not the patient had other comorbidity. You could see from this slide that beta blocker tend to be probably the first choice unless you have someone who is intolerant to beta blocker. Sometimes we avoid beta blocker in severe form of COPD or asthma, but in some patients with asthma or COPD, they still can tolerate a small dose of beta blocker. Digoxin is a good choice, especially if you have a patient with low blood pressure, but we tend to use it as short or mid-term, but it's not as a long-term option. You could see from this slide, amiodarone is not recommended as first or second line because amiodarone has significant side effect and is probably not advisable to use it as a first line. It depends where you practice. You have access to beta blocker. In North America, metoprolol seems to be the favorable option. You can give it in IV format or oral format. It's reasonable to start with IV metoprolol, 2.5 to 5 milligrams every over 2 minutes, and you could give up to 3 doses, and then you could also add or switch them to oral preparation of metoprolol, whether you use metoprolol tartrate twice a day or you could use the extended release format metoprolol succinate. There's also esmolol infusion, which is a good choice because of the half-life of esmolol is very short. So if you have any issue with blood pressure dropping, you could stop it and the blood pressure tend to recover quicker. Usually the esmolol infusion is used in the ICU setting, but it can also be used in the emergency department setting. In Europe and UK, bisoprolol tend to be the beta blocker commonly used. However, it's only available on the oral format, and we still use metoprolol IV if needed. Other option is to use calcium channel blocker, diltiazem or verapamil. These tend to be infusions. You need to be mindful that some of these patients with AFib and rapid ventricular rate, they may have some form of heart failure or diastolic dysfunction, and these strips a lot of fluid, and they may make the patient worse, but they are reasonable alternative to beta blocker. Digoxin again, where you could load the patient with digoxin and then switch them to oral digoxin, and tend to be a good choice for patient with low blood pressure or patient in heart failure. However, it's still not the first line. We prefer to use beta blocker. As mentioned earlier, amiodarone is kind of not recommended unless you have no other options for rate control. When it comes to rhythm control strategy, you have three options. Obviously, the option available for you is the chemical cardioversions, usually class 1C or class 3. We'll discuss in more detail. Or electrical cardioversion, commonly used in the emergency department, and the floor is external cardioversion. But for electrophysiologists, sometimes we use internal cardioversions, where we put a wire inside the heart and cardiovert the patient. And for some patients, we select them for catheter ablation, radiofrequency, or cryoablation, but this is usually done as an outpatient setting. When it comes to rhythm control for chemical cardioversions, your option, it depends whether or not the patient had structural heart disease or not. If the patient has no structural heart disease, then you pretty much can use most of antiarrhythmic medication, but my best option will be flecainide because it's ease of use and widely available and relatively cheap. You could see that amiodarone again is not recommended as first or second line because of the side risk profile, but in some patients it's the only option. If the patient had a structural heart disease or heart failure, then your options are very limited. You could either use Ticasin, dofetilide, Sotalol, or Drorodurone. I'm not sure if these options are available. I know Sotalol and amiodarone is definitely available in Libya. So chemical cardioversion is very important that to treat it as electrical cardioversion. What I mean by that is if you think the patient is at risk of a clot causing a stroke, then chemical cardioversion is the same as electrical cardioversion. The only advantage of chemical cardioversion, it's an option for patients who are relatively stable, but maybe they are not the best candidate for cardioversion, for electrical cardioversion. For example, a patient maybe just had a heavy meal or just eaten a big meal, and you're concerned about giving them sedation or anesthesia, and you want to cardivert them, but the patient is stable and you are happy there is no risk of clot, then chemical cardioversion is reasonable. However, if you have concern about a clot, then it's always recommended you do a transesophageal echocardiogram before you consider chemical cardioversion, or the other alternative, obviously, to anticoagulate them for 3 weeks and then start antiarrhythmic medication. So once again, chemical cardioversion should be treated as electrical cardioversion. The advantage of it is you don't need to give sedation or anesthesia. The disadvantage of it may not work as quickly as electrical cardioversion, and sometimes it doesn't work. As I mentioned, there's several options. If you have a structural heart disease, probably amiodarone is your best option. You could give a bolus of 300 milligrams, and then you could give maintenance. Some institute recommend that you should give amiodarone, especially maintenance dose in central line. Other option is abutylide. It's extremely effective. You give 1 milligrams over 10 minutes. The only concern about abutylide, it causes significant QT prolongation and torsade de pointe. So almost always we give supplementation of magnesium before we give it. And I'm not sure it's available in Europe, but it's available in the US, and I'm not sure if it's available in Libya. Flecainide is a good choice for patient with no structural heart disease. For example, young patient with no prior cardiac history, easily prescribed and given, and very cheap. IV preparation, you could give 150 or 200 milligrams over 10 minutes. In US, interestingly, there is no IV form. They just use oral, so we get between 200 to 300 milligrams orally, but in Europe and the UK you can give it IV. Obviously, once you restore sinus rhythm or you give them IV, then you need to consider maintenance dose to maintain sinus rhythm. So even after you restore sinus rhythm, you may consider giving antiarrhythmic to maintain sinus rhythm. Flecainide for patient with structural heart disease, with no structural heart disease, is my first choice. Obviously, with flecainide, you need to monitor the QRS. If there is no QRS prolongation, then it's safe to continue. And it tend to be the best option for young patient and with an inpatient with no structural heart disease. Obviously, amiodarone is another option, but because of the risk profile and the side effect, need more monitoring. Specifically, you need to be monitoring the thyroid function and liver function at least every 6 months. It's recommended that patients should have ophthalmology assessment once every year. If the patient developed any pulmonary symptoms, then it's recommended to rule out any lung toxicity. For example, these patients may need some form of pulmonary function test or CT scan or chest X-ray. Dofetilide, commonly known as Diclofenac, is commonly used in US, but it's not available in Europe, and because of the concern of QT prolongation, and you can only prescribe it as an inpatient. Moltac or Dronedarone is an alternative to amiodarone, but it's still you need to monitor it, and the risk is not as common as amiodarone. My only concern with Dronedarone is not widely available and it's expensive, so some patients they cannot afford it. Then sotalol, it's widely available, relatively cheap. I think sotalol it's very important to mention that if you give sotalol less than 80 milligram twice a day, then this is just a beta blocker effect. You only get the class 3 effect once you start giving 80 milligram BID twice a day or more. If you decided to start sotalol, it's very important to rule out severe renal failure or severe LV systolic dysfunction, which is a contraindication to starting sotalol. It's commonly prescribed as inpatient because it needs QT and QTC interval monitoring, but there is some practices now where you could start it as an outpatient. It's recommended you do an ECG before initiation, and then ECG 2 days after initiation and 1 week after initiation to make sure there is no significant QTC prolongation. As a rule of thumb, you want to avoid any QTC above 500 or any significant change in the QTC more than 25%. As I mentioned earlier, flecainide pill in the pocket is a reasonable choice, especially for patients who don't want to take medication on a regular basis and patients with no structural heart disease. However, it's very important to recommend that they should take AV node blockade agent when they take the flecainide, for example, beta blocker or calcium channel. This is to avoid that patient when they take flecainide, they could organize from atrial fibrillation into atrial flutter, and obviously atrial flutter can conduct through the AV node quicker, and patient may develop more symptoms, and they can degenerate into serious rhythm. So it's very recommended when they take flecainide pill in the pocket, they take beta blocker for that reason, beta blocker or calcium channel blocker. Electrical cardioversion, again, it's recommended for any emergency situation, any patient with AFib and rapid ventricular rate, and they are in heart failure or their blood pressure is dropping. Another emergency situation if they have AFib with pre-excitation. Again, you need to make sure that they are not at increased risk of thrombus in the heart. For example, duration of the AFib less than 48 hours, or patient is already on anticoagulation for 3 weeks. Obviously, it's very important to make sure that there is no evidence of significant electrolyte imbalance or any drug toxicity before you consider cardioversion. And obviously, each institute have a protocol on the sedation and anesthesia to be performed safely for these patients with electrical cardioversion. Now, I've got this clip to show. It's very important you will be familiar with your machines available for cardioversion. So we like to connect patient to the EKG. We start by putting sync, so you could see that the top triangle marker identifying the QRS. Then we press on the lead and just select to see which lead is the best, showing as the QRS, and it's well synced. So you could see here now lead 1 is the best EKG, where you could see the QRS very tall and you could see the sync marker. Then you select the energy you want. You could go up as much as you want. Some machine you could go up to 360, but we recommend starting with 200 biphasic joule. Then obviously I'll just click on this again. Let me just go back to this video. So you select the energy. When you charge, you need to make sure that the patient is safe, no one is in touch, top, side, bottom, and side. And when you deliver the shock, it's very important that you hold when you press, because the machine wants to deliver the shock on the QRS, and this is why the sync is very important. And let me just stop that. The sync is very important, that you press and hold, because the machine is waiting for the QRS. It doesn't want to shock on the T or anywhere but the QRS, because if it shock on the T waves, it can induce VFib. So it only shock in the QRS, and this is why when you press, you need to hold until you deliver the shock. And once you deliver the shock, you take your finger off, and then you look at the rhythm, whether you restore sinus rhythm or not. So if I could just play this back again. So I'll play this slightly backward. And again, when you press and hold, energy delivered, you need to wait for a few seconds, because sometimes you get some extra beat, and then there's some artifact there. But then you could see clearly here that the patient has P wave and it's sinus rhythm now. So that was a successful cardioversion. But it's very important to make sure when you deliver the shock, sync is on. When you press on the bottom to shock, you press and hold until you hear the shock. And then before you deliver the shock, you need to make sure no one is in touch with the patient, and it's good practice to check the top side, bottom and side of the table. So just to recap, general approach of AFib is you need to confirm the diagnosis, look for any reversible cause and treat them. Then you need to decide whether you need to achieve rhythm or a rate control strategy, and then you move on into assessing the risk of thromboembolism and stroke by using CHA2DS2-VASc score, and this will help you on deciding whether this patient need on long-term anticoagulation or not. We'll skip this slide. It's a busy slide. We'll go to the next one. So the CHA2DS2-VASc score is, you're familiar with the CHA2DS2-VASc score. Now the European are more aggressive. For male, 1 or more. There will be for anticoagulation. For female, 2 or more. They should be considered for anticoagulation, whereas in North America, they're less aggressive than Europe. So for male, you need 2-factor or more. For female, 3-factor or more. So if you have a CHA2DS2-VASc score 3 or more for female, then you need to be on anticoagulation for the rest of your life. It doesn't matter whether you successfully restore sinus rhythm or not. So this is just to decide whether or not the patient needs anticoagulation long term. Now, if you're deciding on anticoagulation, it's very important that you assess the risk of bleeding. So if you start warfarin, it has bled score to assess the risk of bleeding. However, has bled score is not validated for DOAC, but we have now a new score called Orbit AFib scoring system, which assesses the risk of bleeding in patients with DOAC. So you have to use this. If patients are not suitable for DOAC, then we have option of closing the left atrial appendage, but it's beyond the scope of this presentation. But it's an option for patients who cannot tolerate anticoagulation. I would like to conclude my presentation on touching on this subject is atrial fibrillation is always fast. So the atrial fibrillation, the atrium is beating at least 300 beats per minute. What it's slow or fast is the ventricular rate. So it's very important you avoid using the terminology slow AFib or fast AFib. It should be AFib with slow ventricular rate or AFib with rapid ventricular rate. In this example here, you could see that the patient's in AFib, the QRS is irregular but very slow rate. You could still see the fibrillation wave. There is no clear P wave. So this is clear example of AFib with slow ventricular rate. In this example here, you could still see that the patient has no clear P wave and it looks like some disorganized fibrillation wave. But if you focus on the QRS, it looks very regular and very slow ventricular rate. And this is an example of a patient with AFib and complete heart block. And it's very important to differentiate between the two because the management can be different. You need to look at the reversible cause and you may need to consider pacemaker for these patients. So I'm going to skip the last case. On this note, I would like to conclude my presentation, and once again thank you very much for giving me this opportunity to present on the topic of atrial fibrillation, and hopefully next year I will be with you guys in person. Thank you very much.